Welcome everyone to another episode here, Jaws Podiatry. Young patient who has presented to our office recently with a chronic pain to the left heel, present for about 5-6 months in duration. The pain is affecting her daily life activities. Anything else that you would like to say? Obviously the camera's not going to look at you, but aside from it affecting your daily life activities, anything else?
Just searched for many doctors and the band-aids aren't working, the cortisone shot. So
it's funny she says that. You guys all know that I like to use the word band-aids. We're not in the business of band-aids. We're in the we're in the business of solutions, right? In her particular case, we're going to go with a trifecta, right? We're going to go with percutaneous minimally invasive plantar fasciotomy, number 1. Number 2, we're going to go with plantar microtenotomy in and around the area as well. And then lastly, we're going to infiltrate the area with PRP. I really love this combo just because it works so well. Historically, it really depends. When I was in the last 10 years, especially when I first started, the magic number was 6 months to do some type of, relatively semi-invasive procedure or kind of like a plantar fasciotomy. There are several ways to do the plantar fasciotomy. I personally like this approach just because if you do it endoscopically, you have to put, in simple terms, a device from one side of the heel to the other. And there's a lot of, the foot is very intricate. There's a lot going on in this area of the foot and the ankle and the heel. And you can create a lot of damage. There's nerves, there's a lot, and just taking a device from one side of the heel and, driving it to the other, you can create a lot of damage. So, I've done this procedure hundreds and hundreds of times, maybe thousands, and I like it a lot because it's, it's a little bit more conservative, but it delivers the desired outcome and the results. Okay. I promised everyone I was going to try to use a tourniquet this time. I usually don't use tourniquets. It may be a little bloody. You guys won't be able to see much, but nonetheless, I think let's go ahead and try it out, right? So basically the first thing, if you feel any discomfort, just please let me know.
oh, I'll let you know for sure.
Okay.
I got another foot that's perfectly good to kick you.
Okay. Any discomfort here?
Nope.
Any discomfort?
Oh, I can feel it.
But
Yeah, I can feel you cutting.
okay, but pain?
Yeah.
Okay.
Oh boy.
So we have a little bit of, just a little bit of anesthesia here. What I really like about these videos, to be honest with you, is, we don't really, everyone knows me very well. What you see is what you get. We don't edit anything. It's pretty raw, and that's very important. I always tell everyone that transparency is the new currency, and we don't edit anything. Everyone heard the patient say ow, and ow is out. So what I like to do is, I like to be very transparent in that. We're having some camera issues. Okay. You good? You okay there?
Oh yeah, now I'm good.
Better?
Oh yeah.
Okay, good. So we basically make a little stab incision, just like that. Okay. For the person holding the camera, you can actually zoom in and zoom out and get a little bit closer as well. Okay. Basically what we do is we create this little, can you see from there? Let's give everyone, I'm really trying my best here to give everyone a nice little visual there. So what we create is just a little portal just like that, right? And then I take my little special packer. The fascia runs from here all the way here, and we're only looking for the medial band, and it's right there. She probably maybe feels that.
I feel like an elastic band feeling.
Exactly.
But I don't feel it.
So it's right here, okay? What I'll do is I like to create a little port underneath. a little port over. Now we're over the plantar fascia. And now we're gonna create a little port underneath. Sorry about that, you may feel a little pressure. Just like that, that's over. I'm sorry, under and over. And then right here now, over, under, and that's the, you can think of it. It's a celery-like feeling, I guess. That's what we feel at the tip of the instrument. Okay, so what I'll do now, I know exactly where it is. Here's my little scissor. Okay. Historically, there's a lot of people, you can just continue to film while I talk. A lot of people will transect, you know, 20, 30%, 15%. We really don't do a whole lot. In my experience, again, more is not better. So what I like to do is just, you know, with the tip of the needle, I can actually, the scissor, I can actually just feel it like right here. So there's little tricks of the trade that you learn with time, right? And it's a very, very, there we go. No, go down a second. Can you see? Okay, sorry. There you go. So everyone can see. And again, I apologize for the bloody field. You can hear it, right, everyone? Okay. So it's still there. Then I go like this. And that's it. So now, the reason why I'm doing this is because there's something called a windlass mechanism. When I dorsiflex, when I bring the great toe up, the medial band, there's 3 bands, the medial, middle, and lateral. The medial band, I stretch it on purpose. So now, I'm basically just checking to see. There's a little, well, just a tidbit more. Right there. Bingo. Excellent. And then what we basically do, just to double check, with my little spatula, and nada. Okay? That's it. So basically, it's very little. 10%. So now we're going to go to the second part of the procedure. Okay? Elizabeth, can you please get me a 30 gauge,
Yes.
please?
And everything?
Yeah, please.
Just a needle. Here.
Yeah. Thank you very much. Okay. So now the second part of the procedure is, again, I like to combine this procedure with the percutaneous microtenotomy. Come closer, Elizabeth, so everyone can see. So if you feel any discomfort,
Good.
and again, I'm not going to really go into all the details, but what we're essentially doing is just fenestrating, right? The procedure was done over here. This is where we released the ligament, but we never did anything here. So essentially, we're just creating more trauma to the affected area on purpose. And again, why are we doing that? Because we want more blood flow to the area. More blood flow means more healthy cells that will help in the regeneration of all of this. This is an unbelievable, wonderful procedure. A tiny little needle, right? She's been battling this for a long time, and our goal is to provide long-term is the key, long-term relief. That's the second part of the procedure. Now, we're going to hand over the phone to our second person so we can get the PRP. So while we get the PRP, it's already been, we already And again, as everyone can see, there's minimal blood. There's no tourniquet. Next time we can do this live, and then we can have. I used to do a lot of the videos live, but the problem is that we were having some trouble with the Wi-Fi, even in the building itself. We have great Wi-Fi here, and we were having some troubles. So now what we're going to do is we're going to carefully tilt. You got it better? A level? More? You got another one?
Yes.
Thank you, Elizabeth. I'm going to go ahead and inject the treated area. You may feel discomfort a little bit. Sometimes people complain of some dull, achy pain. That's what we're going to do now. Okay? So I'm going to stay here. Okay, we're going to go in through our little incision, drop a little bit here, just like that. Okay, are you okay up there?
Yep.
Super, excellent. You're doing great. Okay, so we'll drop a little bit there. Make sure nothing comes out of there, right? We want all these goodies really staying in there. Now we're gonna come. This may seem a little bit barbaric, but it's really not. Patient is obviously numb.
I think so.
Elizabeth, we still have a little bit more, right?
PRP? Yes.
You felt a little bit of that?
Mm-hmm.
Yeah, the lower heel. I felt
Okay,
it.
let me get just a tiny little bit more, and then we're done with the procedure. So again, like I said, it's one stitch. We're not using any hemostasis here, which means no tourniquet. You really isolated quite a bit. A little bit here. You okay?
Mm-hmm. Oh, I feel it.
Okay, so then the patient feels this, so we stop. And I think that's going to be a little bit here where we do the procedure here. I'm just covering so no one gets sprayed. Okay. We're done with the procedure. 10 minutes, I don't know. Really doesn't matter really about the time, but the point is that it's a very, quick procedure in office here in our office-based surgical suite. Trifecta, number 1, the percutaneous minimally invasive plantar fasciotomy. We released the ligament. Number 2, we performed the microtenotomy here using our deep dry needling technique. And number 3, the PRP to marinate all of the area. This is the easy part. The hard part, it begins the minute that the patient leaves here. Non-weight bearing, the post-procedural protocol, that's the hard part. I hope everyone enjoyed today's procedure.
Except me.
We really have a comic here today, and we always enjoy having patients like herself that really just bring a lot of joy to these procedures. So, like always, if anyone has any questions, I'm going to post this video on our social media platforms. I really appreciate everyone watching. If you guys have any questions, like always, www.jawspodiatry.com, Instagram, Dr. Tojam, Jaws Podiatry, Facebook, and last but not least, our YouTube channel, Jaws Healthcare. Thank you for watching. Okay, everyone, this is just a quick continuation. We just finished the procedure. We put the one little stitch to the incision site, and the question was asking me a couple really important questions. Go ahead.
I'm just curious about any post-pain, what to expect.
Okay, so she's asking about the post pain. So one of the things that are just like I was saying before, when we do these especially the PRP, we're creating inflammation on purpose. So you will have some discomfort for two reasons. Number one, we cut the skin. Number two, we cut a little, portion of the plantar fascia, the ligament. And number three, the PRP and the microtenotomy, the needling. So you will be in some discomfort, of course. But the problem is this is the catch. When we do these procedures, our goal is to create inflammation, right? So when I tell patients, when they say, well, can I take an anti-inflammatory? I say no. Well, what about ice? I say, try not to. Tylenol? Sure. But, usually it's very tolerable. Some patients that, are very sensitive to discomfort, we'll give them a little something mild, right? A little something mild. But we try to tell patients that if they can, for the first 24 to 48 hours, which is, when they feel the most discomfort, try not to take anything. If you have to, then of course,
Okay. The other question is wound care afterwards.
Second question, wound care. So very, very, that's a great question. We'll leave the dressing, okay? The dressing. We leave the dressing clean, covered, and dry during the next 48 hours. We'll see you back here Monday. I like to see patients back in 2 days just to make sure no signs of infection. The patient will be on antibiotics anyways, okay? We give all of our patients antibiotics just to make sure to prevent any type of infection. So when will we see you back? On Monday.
Okay.
Questions?
Nope, I think I'm good. That's my only concern is right now.
Aside from, on a side note, so aside from the, obviously, as everyone will see, when I made my little incision, you felt that. Aside from that, how was it?
It was what to be expected. I mean, I was thinking in terms of being more cortisone shot-ish, but definitely a lot more discomfort in terms of what you inject, because...
So what the patient is saying is that she was not expecting the discomfort, right, from the PRP. The PRP, historically, as everyone has seen in some of our previous videos, I always tell patients, it doesn't really matter. The problem, as well, even though she's numb, the area was numb, and not only was it numb, it was very numb. You still feel discomfort. But we cannot inject, just like I was explaining to you, we cannot inject the local anesthesia into the site, because then it's a big mishmash, so to speak, right? You have something synthetic and then you have living cells. It's not a matter of just like we were saying, it's not, well, you would think that if it belongs to you, there should be no pain. It's not like cortisone or like lidocaine or anything like that. This is volume expansion. You're putting in a lot of volume into the foot. And that's what causes the pain. There are a lot of nerves in the foot. So the patient, was it a little uncomfortable? Yeah. PRP injections could be uncomfortable, period. But tolerable. But everyone's different. My Botox is working, as everyone can see, but we're still waiting for all these to go away, if anyone is wondering.